Hello, my name is Heather Goodwin Peabody, and this is Drug-Free Interventions for Challenging Behaviors. I'm an occupational therapist, and I've been working in mental health for 13 years. I spent 12 years with clients who have dementia. I've worked in a number of settings with them. I've worked in school settings, preschool, elementary school. I am a volunteer for the Special Olympics basketball, cross-country skiing, volleyball, and just a general volunteer. My mother drove a special ed bus. My uncle has anoxia. I've grown up with a lot of different cognitive difficulties in my life. As a student, I had worked with clients at a traumatic brain injury program in Portsmouth, New Hampshire, and at a pediatric summer camp with clients who had very severe cognitive and physical disabilities. I was a private tutor for a boy with autism who was 4 years old, and I worked in a group home as a med tech and life care specialist for two men who had cerebral palsy and very severe cognitive deficits, and a woman who had multi-infarct dementia caused by a lifetime of drug use and abuse. In this course, we're going to talk about non-drug interventions for behaviors. There are drugs out there, but I really think it would be prudent to try to solve things without them. So this is your first line of defense. This course is guided by the following frames of reference: the cognitive disability frame of reference, retrogenesis, the need-driven behavior model, and the ABC behavior model. There are a number of challenging behaviors that we might see with our clients who have cognitive deficits: aggression, hoarding, wandering, exit-seeking, sexual behavior, repetitiveness, perseveration, abusive type of behaviors. And these frames of reference can help us look at behaviors from multiple angles to generate a solution. The cognitive disability frame of reference was created by Claudia Allen in the 1980s and shared as part of her Eleanor Clark's legal lectureship. Her theory was that your client's mood must be stable before giving a cognitive assessment, so that that cognitive assessment will be predictive of how the client will behave in other days. Through looking at how the client will solve problems in new situations, we can predict how our client would solve problems in other situations. It is a very medical model, saying that our client's mood is probably never going to resolve without the use of mood stabilizing medication. It is a model that looks at cognition and behavior and plans for a chronic and progressive condition. Her theories, once the client gets a score through the cognitive performance modes, can help us predict what the client can do, will do, and may do. It is a model strongly based on capability, believing that everybody is capable, just perhaps at different levels, and by understanding which level your client is capable of, you can teach them within that capability. It not only is a model for advocacy, but also one that is guiding for generating and meeting goals. Retrogenesis was created by Risberg, Ferris, and Crook in the early 80s, believing that clients who have a chronic and progressive mental disorder can lose skills in the reverse order that they developed them. Their age equivalents to each milestone that the client goes through, and through understanding typical human development, we can understand a chronic and degenerative disease through a reverse development. The need-driven behavior model is developed by Algase. It is a compromised behavior model that is different from your standard ABC. Algase had theorized that behavior is an expression of an unmet need. He believes that there's an interplay of background and proximal factors which may explain reasons behind behaviors, and it could also identify individuals at risk. This model helps target clients that the ABC model wasn't able to catch, like clients who wander, repetitively yell, or hoard. By meeting their unmet need, these behaviors may resolve. A word on drugs. Pharmacological treatments have limited effects on certain behaviors and may have serious side effects for older adults that have dementia. They also may have serious side effects for older adults being concurrently treated for depression. Drugs have limited to no effect on repetitive vocalizations, agitation, wandering, and passivity. The best that we've been able to do in 2013 is absolutely snow people on medications until they are in a catatonia. The ABC behavior model is a belief that behavior is a form of communication and that the behavior is triggered by an antecedent. Antecedent, behavior causing a consequence. Behaviors have consequences, and it is a guideline to behavior analysis. There are many ABC behavior analysis forms online and available to you for looking at what happened right before the behavior, what happened after the behavior, and what is the actual behavior. Through looking at ABC, it can help us understand a little bit of the intention behind the behavior, but more importantly would be to see what can we do to prevent the behavior, usually by eliminating such antecedents that trigger behaviors, and what can we do to intervene and stop the behavior. So behavior analysis, a full behavior analysis would include looking at what is the antecedent that caused the behavior. There are 3 types of common antecedents, which include psychosocial, environmental, and medical antecedents. What is the actual behavior? Put words to describe what is occurring. What is the need or unmet need that needs to be addressed? What is the consequence of this behavior? Will they hurt themselves? Will they hurt someone else? Is it a health issue? Is it a dignity issue? By answering this, you could decide if it's worth it to address the behavior or if we should just ignore it and let them be. What can we do to stop the behavior? This is the intervention. And prevention. How can we keep this behavior from happening to begin with? Prevention is a lot easier than intervention. So, here are some potential antecedents to challenging behaviors. Psychosocial. Perhaps they have something in the environment that is affecting them. Do they have a roommate that makes repetitive vocalizations? Is there an overhead pager? Are they uncomfortable? Is there some sort of caregiver that it isn't a match with? Has someone recently died in their life? Medical. Are they having digestive issues? Also under psychosocial, did they misinterpret what you said? Did you say, let's take a shower, or let's take a bath? They're very concrete thinkers, and they might think that you meant to, and it results in a sexual interchange. Medical, they could be having pain or a hallucination. Oftentimes, the antecedents are some sort of change that happened in the client's daily life that triggers a behavior. Let's go over some tricks of the trade to help manage common issues that we see with our clients' behaviors. Active engagement pulls a participant out of a passive state, expending energy, providing pleasure and movement opportunities, and reducing other neuropsychiatric symptoms. Activities are the #1 way to reduce behaviors. The best way to manage a behavior is to prevent it from happening to begin with. Increase independence and give control whenever possible. Not an open-ended, do you want to get dressed? They never want to. Don't say, do you want to? You could give a guided choice. Do you want to wear your red shirt or your blue shirt? By providing a guided choice, they can give you a simple answer. By saying, do you want to? That's yes, no, and that's just poor sales. Eliminate poor lighting, shadow, glare from mirrors or windows. Reduce excess noise. Don't argue, don't correct, convince, or take behaviors personally. Anger is a very hungry emotion, and it takes very little to thrive off of. Acknowledge and validate feelings whenever the client is upset. I understand that you're upset. Distract with food, drink, or physical activity. Identify something comforting that might be unique to the client. Put labels around the client's environment so they can find their way around and they won't get frustrated if their cognition limits their environmental access. Provide the just right assistance to complete an activity. The client should feel slightly challenged, lose track of time, and when they finish, feel a sense of accomplishment. If being direct doesn't work, you could always be indirect. Instead of saying, get your socks on, you could say, after you get your socks on, do you want to wear your black shoes or your brown shoes? Even more indirect than that would be, after you get your socks on, and then your shoes, do you want chocolate ice cream or vanilla ice cream? never telling the client exactly what you want them to do, just implying it through subtlety. Some clients also don't like to be observed, especially when using the toilet or eating. They might not want to be watched. So you can always be indirect. Be in the area doing your own thing while watching them peripherally. Behaviors that we will cover include hoarding, passivity and aggression, social isolation, depression, pain, sundowning, refusals, noncompliance, playing possum, fight-flight response, uncontrollable laughing or crying, paranoia, sensory processing impairments, modulation difficulties, sensory deprivation, perseveration, diurnal rhythm disturbance, yelling, sexual behaviors, wandering, elopement, hallucinations and delusions, excessive emotions, reducing responsibilities in one's life by having a negative response due to their lack of insight, financial interventions, reducing driving, grieving behaviors, and some ideas for goal writing and case studies. Stay tuned.